So now we are going to learn MSICS for the Phaco surgeons. Yes, you have read it right. From Phaco to SICS. So first, let's differentiate between the facts and the myth. Many people think that Phaco is a new technique, SICS is an old technique. Phaco is a good technique and SICS is not so good technique. So Charles Kellman, he introduced Phaco in 1967, whereas Blumenthal did it in 1992, a good 25-year gap. So SICS is 25-year younger than Phaco. And now let's get off all this preconceived notions of which surgery is best. No surgery is best. You have to choose right surgery for right patients. Like I would encourage everyone, including especially the young residents, which procedure would be best for this patient. Let's raise hand for A, for B, for C, and for D. Okay, so as by the counting the hands also, it was SICS which could do justice in this case. And suppose it's an old patient with this kind of plaque and cataract grade, SICS would definitely do a better visual outcome. It will give a pristine cornea, especially on the next day. And now this, how many for ECCE on this patient? A, raise your hands. B, SICS. C, raise your hands. And what about D? So yes, the most will do a Phaco in this patient because we want a closed chamber and, Phaco will deliver a good result in this patient. And what about this? A, how many? B, C, and D. Yes, this is a clear-cut case for D, I think, because the only problem in this kind of cataract is rhexis making. It will go haywire, it can run anywhere. So FLACS will do a wonder in this patient. Once you get a good rhexis, you can do it. And what about this last one? A, B, C, D. Yes, I think again it's D and probably combined obviously with C. So this is how we choose correct method for correct patient and correct cataract grade and situation. So no technique is perfect. Everything has its drawbacks. So we have to choose the right method. And for that, you must learn everything from the modified ECCE, which Professor Malik just explained, till femto probably, yes. And what you will do in this, suppose you are doing Phaco and you land up in this. So now, who will save you? Probably SICS. So, which anesthesia is best for SICS? Because from Phaco, when you are migrating to SICS, this will be the most trickiest part. You are habituated in doing topical and suddenly your patient eyes are moving, you are not able to make the tunnel. So which is best? So initially it is obviously peribulbar, start with peribulbar. Once you are confident in SICS, you can always do topical. In most of the patients you can do topical. Obviously you have to select, it cannot be like I do topical in all, it cannot be like that. It has to be patient preference also and his pain threshold bearing capacities. As everyone is agreeing now that it can be done topically. I am doing topical SICS since last 5 to 6 years. No problem at all. Even you can do cautery in that. Patient does not feel pain. The block is at the surgeon's mind. It does not be required at the patient's eye. So now let's have a look at a video. It's topical. And it's transconjunctival and I'm doing a modified customized incision because it was steep axis was temporally, so I'm doing a temporal incision. Initial this part may be difficult for beginners, especially under topical, but once you achieve the second plane, then things are absolutely smooth, and it's just a matter of practice and patience. So I would just fast forward it little bit. Pockets should be well made in SICS because it's a snake mouth kind of tunnel you are trying to create, in which the inner pockets are larger than the outer incision. So this is the pocket making. Now I do 90-degree this capsulorhexis using Utrata. It gives me better control, better hold. Then entry. This is the most important part. It should be in a straight line on Descemet's. Hydro like you do in Phaco. The only difference is we try to pop it, because once it gets popped, half of your troubles are gone. And then, as Professor Ruchi Goyal has explained various methods of nucleus delivery, you can use any one which you like. You must try everything before settling on one, because again, as I told you, you will require different set of skill for every patient, and you must deliver best for each patient, and that you can only do when you know everything. So this was a simple hydro expression of the nucleus. And after cortical cleanup, using both ports, I do a hydro implantation. You can use a PMMA lens also. It depends on patient's choice. They want sometimes better lenses, and sometimes it's difficult to argue with them that PMMA is better than most of foldable. And one more myth, you can implant a multifocal or something like that in SICS also. But once you should be comfortable of your SIAs. So again, the other thing in topical SICS, or when you are trying to convert from Phaco to SICS in between the surgery, you can use this marker. This marker is very helpful. Just a little small video. The same video which we saw today. I'm from Varanasi, and this is famous Varanasi Ghats. So this is Ranjan marker. It has a serrated edge which holds onto the globe, and now you have this stencil-like thing which will give you a frown-shaped incision of 6 mm. You can increase it, and the rest of the surgery is almost same. So if you are not comfortable with a tooth forceps, topical Phaco, topical SICS, you can use Ranjan marker, and this would help you in creating a good tunnel. Thank you very much. I would appreciate any questions.
Only Pratyush, this is, yes. Mike, till then I ask, Pratyush,
Sir.
This is a marker you designed well. I tried it, you know, but only thing is, I think very good idea to have a transconjunctival incision and going to sclera and then tunnel making. I think then you save lot of conjunctiva and you save lot of stem cells. But conjunctiva clean cutting in old people is difficult.
Yes, sir.
That straight line cutting of a conjunctiva in old person, because it is lot of looseness, and making it a straight cut through your marker also, sir, I find it difficult sometimes. Either I hold it and then make a small cut first in conjunctiva, and then you use your marker on the sclera.
Yes, you can do that also, sir.
Ah.
But again, yes, like all skills and all surgeries, nothing can be, 100% for every patient. We have to be,
No, you solution for conjunctiva only.
yes,
That conjunctiva cutting, how you make it simple?
yes.
That does it cut with the marker well?
Yes, sir.
You have cut it well, I could not.
It's just practice, sir. Just practice.
Yeah. So,
excuse me,
this
sir.
marker has another good thing is that you can go any angle you want. It has angles also. So use this marker. It must be available.
Yes, sir, at Epsilon counter. Epsilon is marketing it.
हाँ बेटा बोलो.
Sir, the thing about the
अपना नाम बताओ और कौन से शहर के?
myself, Dr. Arpit Sharma. I am from Dhar, Madhya Pradesh.
Good.
Sir, about the transconjunctival flap, shouldn't we take the flap and then give a scleral incision to reduce the risk of infection, because conjunctiva also helps to reduce the risk of end off and all.
Once I do transconjunctival, I am sorry I didn't show you the last slide. Can I have this video again? Please allow this.
क्या कह रहे थे आप? Problem with the conjunctiva is that you lift the conjunctiva first.
No,
Yes,
no, he is not excising the conjunctiva. He is simply
it.
obviating one of the steps. So the conjunctiva is going to be there to cover your wound. So don't get worried.
Yes,
about
and
it.
at the end I am
Yeah,
quartering it. I just want to show that video, please. Console,
And
yes.
Only thing is, like, it's a little difficult to sometimes dissect with the conjunctiva on. So you just notice continuously there was fluid being poured onto it, so that you have a very clear view of where his plane is. That is one thing which is difficult if you have a conjunctival flap covering your sclera.
So, why there is a need of transconjunctival? Why shouldn't we?
He's, just to make your surgery faster.
Just a different technique, just
Just
a
that's
different
all.
technique. Again, I'm telling you, all techniques should not be applied like blindly to everyone. But what are the advantages of doing a transconjunctival? First, it saves you limbal
Right.
cells. Second, it saves cautery. And, over cautery can induce astigmatism, scleral melts. So it saves that time, and little bit of bleeding actually helps in good seal.
Healing.
And actually, little bit of bleeding will cause such adhesions that your bacteria won't enter. And, just see the last step. I think I forgot to show that. So how I am covering that conjunctival wound. The sclera is self-sealing.
Injecting saline.
Yes, sir.
Don't inject antibiotic on this area.
Saline.
This is my advice, that because you have opened the wound, any genticine going into the chamber, vitreous will produce optic atrophy. Please, if you inject any antibiotic, do it at 6 o'clock, side anywhere, but never at the site where you have injection. If you want to inflate the conjunctiva the way he did, can be done by saline.
See, this is how I close. If just hold both the end and do a little bit of cautery.
And SICS also, like, you can do without cautery, really. Bleeding takes its own time, and by the time you are through with this SICS, your whole bleeding has stopped. Initially on microscope it would look bad, that there is there, there's a clot there, this one. Once you clean that up,
Yes.
everything is so good. And in fact the fibrin which has been produced, as he said, that will close everything so well. Conjunctiva will sit back, the sclera will sit back, and doing SICS without cautery is wonderful.
Thank you, sir.
won't get a problem.
Thank you.
Any more questions? So I would invite Professor KPS Malik sir again to talk about ABC of Phaco. I learned Phaco from him. I learned SICS from him. And it was wonderful experience at Safdarjung. First year PGs would do ECCE, second year SICS, third year Phaco.